everybody. It's my pleasure to introduce Greg Alexander. You've probably seen Greg around. He's sort of become part of the furniture over the last couple of months. Greg's a professor at University of Missouri, Sinclair School of Nursing, but also he's a Fulbright scholar, and he's been visiting us since January. He's done a lot of work on aged care, and we're extremely happy to have him with us and look forward to your talk today. So welcome, Greg.
All right, so let me get my fat fingers to work on these things here. All right, so I'm a registered nurse by background, and I was trained during my PhD program in the United States. I was trained through a National Library of Medicine informatics fellowship. So I have a strong informatics background. I have a master's degree in information science, and I've studied a lot about human factors and other types of things that are really important when you think about human-computer interaction and technology use. And I specifically focused, my dissertation was on, which I finished in 2005, my dissertation was focused on clinical decision support systems in nursing homes. And I did an evaluation of a clinical decision support system in 5 nursing homes that implemented an electronic health record and looked at the alerts and how they worked and how they affected nursing care. And so that work has transpired into what I do now. So I do a lot of work in aged care. I shared some work with some of the colleagues here and another center about vaccinations. So I do a lot of work with our large data sets and looking at vaccinations and how they are implemented in aged care and how we track those. And now, though, I am, in the last few years, since 2012, have been involved in a national demonstration project in the United States. It's a national demonstration project that's funded by the Centers for Medicare and Medicaid, and the CMS, Centers for Medicare and Medicaid, is our funding agency for aged care facilities. So it's Medicare, similar to you have Medicare, except our Medicare is specifically for aged care facilities and retirement types of activities. And so maybe a little bit different than your setting, but same issues and same opportunities to improve. So I'm going to talk a little bit about that. It involves skilled nursing facilities, and I'm interested in improving quality of care in skilled nursing facilities and how to do that best. And so let's see, something happened. There we go. Fat finger syndrome. Okay, so like I said, in 2012, we started this Centers for Medicare and Medicaid project. This was a national demonstration project, so 7 sites in the United States were funded under this proposal. Our funding stream was for $13 million. So for 4 years, we got a $13 million grant to implement our model of care in nursing homes. And our nursing homes are similar to your residential aged care facilities. They provide high and low care. We have a system of acuity that we can measure, similar to your high and low care. And funding is based on that model of understanding what high care and low care means. And so we were very interested in building acuity, providing higher care to the residents in our skilled nursing facilities and preventing them from going to the hospital when they got sick. So we needed the nurses to step up and to be able to accept more of a higher acuity patient and to be able to take care of those in the long-term care setting and keep them there versus transitioning them out of the hospital. And that required us to talk to the physicians and the other team members about what we were trying to do. So I'm going to talk a little bit about that project and the results of that project. So what we did with that project is we implement what's known as Interact tools. Anybody know what Interact is? Interact is a standardized form of communication that people in healthcare utilize in the United States. It's been validated. It's a very reliable instrument that's a standardized way to communicate a situation a background of a resident, some assessment parameters, and what the recommended treatment is. It's called, one of those forms is called an SBAR form, and that's what I just described. There's another one called a stop and watch form. Stop and watch is what nurses' aides use, nurses' assistants or carers which I believe is what you call your nurses' assistants in most cases. The carers would fill out a stop and watch form when they detect that something has changed in an aged care facility, and they would send that stop and watch form to a nurse to be able to evaluate how they're going to communicate with a physician. So we utilized Interact tools and processes, which are standardized tools, and we put advanced practice nurses. Advanced practice nurses are nurses with a master's degree or higher that have a specific certification that allows them to write orders if they have a collaborative practice with a physician, and allows them to do certain types of activities above and beyond what a registered nurse can do. I'm not an advanced practice nurse. I did not go to school to be an advanced practice nurse, but I understand the role that they play. And there's a lot of tension between advanced practice nurses and physicians in the United States, because advanced practice nurses are trying to take over some of the role of the physicians and the payment that they receive for that. So there's a lot of tension in their work. Yes?
Is that like a nurse practitioner?
Yes, yeah, or a clinical nurse specialist, we would call that. So it's very much the same thing. So we put one of those in each of 16 nursing homes, utilizing the Interact tools and modeling care. And then we provided coaching, and we provided care provisions without writing orders, because our nurses, our advanced practice nurses, did not have collaborative practice agreements, and so we did not go that far. We just wanted them to model good communication and to be resources, and we were trying to develop better connections. And so how we did that was we did that with the APRN. My part of the project was to implement information technology, so I implemented a health information exchange, which allowed these documents, like Interact documents, to be exchanged electronically in a secure way through a portal. And so I implemented that in 16 facilities and built the network around that. And then we also had a focus on advanced directives or end-of-life planning, so that people can make good decisions about the end-of-life care that they wanted to receive. So some of our outcomes, we were very fortunate in that we were one of the highest performing demonstration projects out of the 7. So our model worked, and how it worked, how effectively it worked, we were able to decrease the probability of any hospitalization in the 19 facilities, or 16 facilities, by about 9.3%. So 9.3% hospitalizations were reduced out of all of those that were eligible beneficiaries. And we had over 2,000 eligible beneficiaries that were participating, and the individual patients that we were taking care of. And so, so we prevented a lot of hospitalizations, which saves CMS, Centers for Medicare and Medicaid, money each time that they prevent one. We reduced the probability of potentially avoidable hospitalizations by 7%. So we classified our hospitalizations by those that are unavoidable and those that are avoidable. And we targeted the avoidable ones that our APRNs, advanced practice nurses, could make a difference in, because if we have better skills and better tools, then we should be able to care for those avoidable patients better. We reduced the Medicare expenditures for all-cost hospitalizations by about little over $1,300, and then potentially avoidable hospitalizations by about $500, a little over that. And this was written up in a report in Health Affairs just a couple of months ago, where our projects were compared to all the 7 projects. And so we were proud of those numbers. In fact, CMS was so proud of them, they funded us for another 4 years. Only what they're doing with this money that we saved them is now they're paying it back to the hospitals, or the aged care facilities. So the nursing homes now are receiving the money for each hospitalization that they prevent. So what we're doing is we're implementing the same model, and we are adding on a payment. if they prevent the hospitalization, which is a big incentive for them, because then they can receive thousands of dollars a month if they prevent hospitalizations. But they have to do that safely. And of course, you know, CMS, Centers for Medicare and Medicaid, are really monitoring that to make sure that we're not shirking care and that they are really providing and getting the care that they need. So over the years, the quarters that we looked at this data, you can see that this is the relative hospital transfer rate per 1,000 resident days. That's how we standardized looking. And we had feedback reports that we gave to each facility that provided some details about how they were doing each quarter. And we trended those results. And so from the very start of the project to the very end, you can see how we lowered our number of hospitalizations. In the beginning, they were fairly high. In fact, in St. Louis, where this project took place, we had some of the highest hospitalization rates in nursing homes in the country, which is, I think, why we got selected. So we were starting out on the upper end, but we were also chose homes that provided really good quality care. So we knew the homes that we had, the impact that they were really going to be strong impacts, because they weren't bad to start with. That wasn't the reason the transfers were happening. So as you look across here, you'll see there was a major drop here in these quarters here between 14 and 15. And the reason for that, we think, is because then we started providing really strong feedback reports to these facilities so that they could compare how they were doing one to the other. And it sort of created this competition between them. Ooh, we need to do better. We don't have as good of rates of hospitalization prevention than our other people. And we had leadership meetings where we talked about that and showed these things. We have another example of a feedback report here where we provided this, and we gave this to them every quarter. So each facility is represented in this, and you can see over the period of time that the quarters are there that 12 of the 16 facilities had improvements. 4 of the facilities that did not have improvements. And the reason those 4 facilities didn't have improvements, we believe, is because they had turnover. They really had a lot of trouble with administrative turnover, staff turnover, those types of things, and they weren't engaged. A lot of them didn't like the technology that we were implementing, and they weren't really incredibly eager to do that. And so they were sort of the laggards, if you will. I wouldn't call that to them in a leadership meeting, but I'll say that here because I'm a long way from home. But they were laggards in a way. They took a lot of convincing to get them going. And now that we've added a payment model, a lot of our facilities are like, ooh, I can get paid for doing this now. So they're more eager to participate in that kind of work. And so you can see they were all at different various rates of improvement. Some of them very steep, some of them not so steep, whether they were improving. This is then in review now at the gerontologist. So we're trying to publish this data as quick as possible. So I'm going to provide you a little bit of some data around some of the hospitalizations that we have. So this is a descriptive report of over 4,000 resident hospitalizations that we had. And what we did was we had each of the APRNs report specific information for every hospitalization that occurred in their facilities. So these reports come from the number of APRNs that we're working within each of the facilities. We had 16 APRNs at any one time in each facility, or across all facilities. But we had probably more APRNs than that because we had turnover as well. We had some APRNs that left, and so somewhere between 20 and 25 APRNs total, I think, for the project for this period of time. And what we had them do was we had them enter data into a Qualtrics survey mechanism, and that provided some details that we would not normally have had about hospitalizations and why they were occurred. And of course, this related to the use of the Interact tools that I talked about. So I'm going to provide some data about that. This is just descriptive data because I know I have statisticians in the room, and I'm good at descriptive data, and I need a statistician for other kinds of data. So I'm just going to stick with what I know. This is reasons why some of those 4,000 hospitalizations were admitted to the hospital or were transitioned. We have a situation where about 24% 5% of those visited the emergency department only. That is something that's probably an avoidable hospitalization, because if they go to the emergency room and then they're sent right back, chances are we could do something for them. So this was a target area that we looked at. We also had some people that were held for observation. And in many cases in the United States, hospitals have this observation status types of status for residents that come, and they'll hold a resident. As long as they hold them for 24 hours or less, they can bill for certain types of activities and then send them back, and they're not like, they don't, there's some criteria that they track that, in relation to their admissions, that it affects their reimbursements rates in some ways. And so the observation status is good for the hospital, not necessarily good for the patient, because they're away from what their normal surroundings are for a 24-hour period of time, but then they're sent back. So, very minor sorts of interventions occurring there. Again, these are avoidable hospitalizations because of the way our payment systems are set up. Observation status occur quite a bit in this setting. Then we had 72% that were actually admitted to the hospital, and some of those were avoidable as well. If you look at why people were sent to the hospital, we were always looking at this kind of data because it helps us understand what population was occurring. It was either because they had a change in mental status, which was probably a good reason to send somebody to the hospital. Functional ability was declining. Sometimes that was an avoidable problem. Sometimes it was not, especially if it was related to some sort of TIA, a stroke, or some sort of other types of decline in their ability to function. Behavior and pain level were the top four areas. That's why they were sent following an acute change in condition. And the important thing about this acute change in condition is when a person has an acute change in condition, in the nursing home it triggers a whole cascade of events, including a lengthy long-term care assessment, which is a very lengthy, about 24-page document that documents several systems, human systems, of physical systems and cognitive systems. And it's a very time-consuming process that while they're doing that assessment, in some ways it takes nurses to do that, and it pulls sort of nurses away from the actual caregiving and doing the documentation. So acute changes in conditions are very important to watch because that trigger of events, and it also stimulates payment. So how they react to a change in condition and whether they send them out or keep them is really important. When we looked at the symptoms at times of transfer, this is important because this can help us have an idea of what sort of resources are needed to manage the systems. And we'll talk about resources here in a minute. But abnormal vital signs are important, and understanding whether or not nurses know how to respond, or even nurses' aides know how to respond to an abnormal vital sign and what is an abnormal vital sign in a resident. So if a resident has a really low temperature, oftentimes older people that are living in these facilities will have a lower than normal temperature, and that's normal for them. It doesn't necessarily mean that they're near death or that kind of thing. And sometimes that lower temperature, if they do have a temperature, sometimes their temperatures are not so high, so you may not be able to detect an infection because that temperature is low to start with. And so, if they have a temperature, it may be within a normal range. And so helping people understand those dynamics of treating older people and caring for older people helped us to prevent hospitalizations, knowing what was normal and not normal for them. Pain was a huge issue. Breathing difficulty and confusion were our top four here. These other categories were an issue because sometimes you just couldn't put something into a category. It's sort of the problem of these types of things. Sometimes you can't have enough categories to put everything in, but so our other categories sometimes seem to bubble up, and we were always looking for those, at those independently. But we felt like our symptoms were the classifications that we had were pretty descriptive of what occurred. The time of day of when this occurred was another area of concern because we didn't have APRNs around the clock. And APRNs also were on call, similar to physicians, but they had to have a time off. So their time allowed for this project was important. So we tracked that. And so 37% of our people that were transferred to the hospital occurred between 12 and 6 p.m. So 6 p.m. to midnight, 25%, nearly 25%, were transferred. And that's the time when the RN was not available, when the APRN was not available to help. Fewer in the daytime. They occurred most every day of the week, but our APRNs did not work every day of the week. They worked 5 days a week. So Saturday and Sunday, people were left to fend for themselves. And sometimes the APRNs would make themselves available through beepers or the technology that we had available, and sometimes not. We were looking at advanced directives of end-of-life care. This was important because if people had chose not to have any end-of-life sort of support, so if they chose not to have CPR, which was a difficult decision, then oftentimes that could be translated into do not transition to a hospital. Sometimes people with full no-code orders, in other words, do not provide CPR, were transitioned to a hospital. For what purpose? Because there was nothing the hospital could do that any differently than the long-term care agency could do. But helping people understand that it was something that was very important to this project. So we tracked this, and we had 46% say do not resuscitate, 50% said do CPR, and then there were 4% that were sort of the other. We had a program called Crucial Conversations that we implemented. This is a standardized program where you have, it teaches people how to communicate and have crucial conversations about end-of-life issues. And so oftentimes those are very difficult to have. And helping people understand how to negotiate those conversations helped us to have those hard conversations with family members, and typically it's the family members and not the patient that you're really dealing with in those kinds of decisions. And even though the patient's still an important part of that factor, sometimes they have different points of view. And so understanding those end-of-life decisions are important. We tried to make sure that everybody that was in our project that was eligible for our project had a healthcare directive, so some sort of directive about how to manage their care. How many people in here have a health directive? Oh, 4. Good. So healthcare directives are very important because they provide the body of people providing the care directives on what you want in your care. So helping people understand that that's a very important document to have, to carry with you and have in your medical record so people understand what care you want is really important. Otherwise, if you're not able to tell them, they're going to decide for you. Yikes. So that could be
Are they legally binding in the States?
healthcare directives, yes. To some degree, if they're part of your medical record and they're authorized and signed, yes. However, there are times where medical providers will, for various reasons or other, will choose to do things that are maybe not quite what the health directive intended. Sometimes that depends on the relationship that the person has with the physician. One of the things that we found is that in some of our research is that physicians that don't follow health directives oftentimes have a difference of opinion about in their own health directive. So if they have a health directive, their desires and wishes that are spelled out often become what they choose to do in the residents and not follow the residents' own decisions. So it's very much internally driven, by how you evaluate those types of things. But I would encourage you to think about having one because you never know. Issues that increase risk of hospitalizations were things like, these are probably typical things, polypharmacy, anything greater than 9 medications or more. Actually interesting, our quality measures in the United States in nursing homes, they've stopped tracking those because most everybody in a nursing home is on 9 or more medications. So they've stopped tracking those, which is interesting to me. They've tracked specific ones now, like antipsychotics, antidepressants, vaccinations, those types of things. People with multiple comorbidities and dementia are the top 3 that are outlined there. So, sort of the interventions that were attempted across these 4,000 hospitalizations were new medications, 23%, IV or subcutaneous fluids, 4%, increased oral fluids, 12%, oxygen, 29%, and others, 31%. So this one was an area that we worked on. You could provide IV fluids in the nursing home, but a lot of the nurses didn't realize that. They didn't realize that you could provide a certain amount of IV fluids. Oftentimes they didn't even have the resources they need to provide IV fluids, unless it was an emergency situation. But if it was an emergency situation, they typically called the ambulance and let the ambulance come and get them. So we did a lot of education around hydration and providing IV fluids and tracking these types of systems, and we believe that that contributed to our overall improvement in hospitalizations, because you keep people hydrated and oftentimes they're going to be a whole lot better. Just even providing a cart with water available on it that people can get to, and that somebody is designated to give somebody a drink of water, is key, because a lot of these people are having mobility issues. They can't get up and get themselves a drink of water, so they're dehydrated half the time anyway. So providing somebody that the impetus and the responsibility of giving a glass of water to a patient provides better hydration and can prevent a hospitalization, just something simple like that. It's just processes of care, and how's that going to work into your workflow? So increasing oral fluids is something that we did. Some of these other things like oxygen and those types of things, oftentimes if they get to the point where they're providing oxygen, they're, or they're changing oxygen levels, they're already thinking, I need to transition this person out of here because they're having more oxygen needs before it gets too bad, where I can't handle it. Our goal was to try to follow their desires and try to recognize the illness early on, so early onset recognition, and to provide that early so that you can intervene and have a better impact before they were already in the hospital. We looked at some of our interventions and we sort of created this word cloud, which I thought was sort of an interesting way to visualize how people documented what they felt were important interventions. And the important interventions you can see are like sort of in this area. So the larger the words, the more significance they had in the significance, not a statistical term, but significance in the number of times that it was actually used in the documentation. EMS is like the 3rd largest. So that tells us the story out of these 4,000 pieces of documentation that the APRNs and the people that were managing these people thought of EMS, most or the majority of time when somebody was having a change in condition. And there's other types of things here that are on the outskirts, and this is where we focused our education and trying to understand the resources that were required in the nursing home and providing those resources to improve the level of care that they could provide for these really sick patients. Because our nursing homes are going to become the hospitals of the future, I believe. I think people are not going to be moving out back and forth from the hospital to the nursing home as often. I think CMS sees that as a financially not a viable system. Hospitals are going to be for things like x-rays, very acute care, like ICU kinds of stays, but for your day-to-day kinds of things, nursing homes are facilities that keep elderly people that need care, high acuity care, are still going to be there. Either that or they're going to be in the community and they're going to try to live on their own. And so we have other venues and other ways of caring for these people at home. And I have another presentation about that, but I'm not going to go into that here. So testing attempted, this is sort of the testing that is attempted. This is important because, so my work here in Australia is looking at the infrastructure and what types of things are being done in aged care. So I go in and I talk to them about how do they connect with laboratory systems, or how do they connect with radiology systems. And so when I go into a nursing home here, and even in the United States, when I go into a nursing home and ask them about these things, they're like, we don't have those, the hospital has those. Well, then I start questioning. I'm like, well, so you don't order labs and you don't get labs for people that are in your facility? Yes. Well, how do you get that information? Well, sometimes it's fax. Sometimes I have a screen on a computer that I go to and I look at those results, and I'm like, okay, well, you have a different way, a different infrastructure for doing that. And that technology, I believe that if we use the technology to its capacity, that these kinds of things that the nursing home don't have, it allows for earlier intervention because the labs can run the tests and shoot the result back to the nursing home and allow them to react faster than if they were relying on some other form of communication, like a phone call or something like that. So there's a lot of room for building in better systems. So most of our types of tests that were run were lab tests. We did have a few that had EKGs, urinalysis and cultures, venous Doppler. We had several that had a venous Doppler, which is interesting, whether they thought they had an embolus or something like that, an X-ray or other. So these are all sort of process controls. And my job in this was to go out and find out what types of lab contracts they had, and I would work with those labs and work with the nursing homes to create a portal and exchange where they could exchange this information back and forth to see if we could provide earlier intervention by getting results quicker. And I think that's another wave of the future, because most nursing homes don't have that capability here or there. Evaluation by a clinician, this is sort of telling too, whereas almost 60% of the patients of these 4,000 were evaluated by telephone. So very few clinicians were seeing them. So in this new payment model, in the second phase of this project, nurses or advanced practice nurses or MDs are paid to go in to see them. They actually have to go in and make a physical assessment, or they could use telemedicine. So they're encouraging the use of technology for interventions in this setting, even more now, because they recognize that if you put a patient or resident or somebody in front of the doctor or the nurse, they're going to be able to evaluate them better than a simple phone call. And typically these messages before our intervention were scattered. People didn't, in nursing homes, they oftentimes didn't use structured formats for discussing. So the Interact tool provided a structured format for discussing this types of issues. How many were evaluated by an APRN that had a hospitalization? 72% were not evaluated, which is interesting. Imagine if everybody was evaluated by an APRN or a physician. What the difference might be. So we have a long way to go and a lot of improvements to have. And one of the reasons we believe this was so high was because there was no incentive, there was no payment for them to go in and do that. They could just use the phone and call and then not go in. So the reason why they weren't evaluated was the APRN wasn't on duty. So this is another reason for using telemedicine. Another reason for using other types of technologies that will connect the nursing home to a provider when the provider isn't in the direct vicinity, because our providers in the United States aren't local. I mean, they don't hang out in the nursing home. They're usually in the hospital or in their office. They're not in the nursing home. So I think it's the same way here. The general GPs are usually not. So how can we improve that, and using technology to do that? So opportunities for improvement is, the top one was the condition might have been managed safely in a facility with available resources. So each facility needed better resources. One of the things with the technology we found, we did a readiness assessment of all 16 facilities, and we found that they didn't have scanners, they didn't have printers, they didn't have laptops, they didn't have computers to use for staff. Most of those things were in the business office, which was closed at 5 and locked. So nobody had access to those things. So through this, we provided this grant, we provided some infrastructure for them. We gave them scanners and we gave them printers and laptops and computers, which helped them have access to some of the lab resources and some of the other resources that we needed to be able to exchange documents. And there was an other there in the middle, and then changes in resident condition might have been communicated better, so communication was a huge issue. There was a lack of good communication across these resources not available. You can see the other one at the top there, but if you look down through here, lab or other diagnostics or equipment. So we were really focused on trying to improve this in our work in some ways by trying to work with the contractors to see what we could do to improve services and get them there quicker, because in order for a patient to be kept in a nursing home, they needed to have services immediately or right away within a certain amount of time. Otherwise, they just call the hospital. So we did another word cloud with other types of resources, and you can see the sort of types of things that they're interested in. CT and blood and scanning and those types of things, MRI, X-rays, and those types of things are all sort of at the tops of the list. How many transfers were preventable? About 53% we felt like were preventable. So, you know, half of those 4,000 were preventable. If you knock the number of transfers from 4,000 to 1,800, that's a lot of money to be saved from our government in care. And they recognize that, so that's why they funded us for another 4 years to try to impact that number right there. So I wanted to say that this project is a multi-component intervention. I've talked about just an overview. This was a huge project that led where I was a co-leader, and I had a person reporting to me that did health information technology and who visited and implemented the network. We had a social worker with advanced care planning and a social care transition coach in the community. We had a physician medical director that worked with all the physicians. We had a quality improvement coach that went out and went to all the quality improvement meetings at all 16 facilities. We have a team of probably about 20 people on this, so it's a large project, which is why it was such a large amount of funding. The second 4 years, which we just started in October, is $19 million. So what the government expects us to do is to save that amount of money in the implementation of this model, and what they'll do is to pay that money back to the hospital or the nursing homes for keeping those residents there. So we're hoping that it continues and continues to get better. Some of the recommendations are: don't transition your people, keep them in the home. Stop problems before they start, keep people hydrated. Falls are a big issue, so stop, prevent injuries, recognize when injuries can happen. A lot of root cause analysis types of activities go into this, and loss of function is an important one. So recognize decline and what do those symptoms look like, because they're different for adults, geriatric adults, than they are for adults and young patients. Improve communication within and between nursing homes. This is really critical. That's part of the technology bent. And then use APRNs and RNs to help facilitate crucial conversations, get people to talk about their end-of-life decisions so that you at least know what they want, so you can do what they want, so you're not spending excess dollars on things that aren't really needed. This is our team. These are our core team members, so these are from the University of Missouri. Like I said, we have probably 15 to 20 staff members, excluding the RNs, APRNs that surround us. So it's a really large team, and I couldn't do this without them. So that's that. of the things in regards to the technology part of it, all of us that have each dimension that we're focusing on are trying to show the impact of our individual component. One of the problems we have in the United States that I've recognized is that when you're developing a health information exchange, a secure information platform that a network like this could use to exchange information, most of the health information exchange providers will not let you have access to their money, or not money, access to their information and their data because it's secured, and the people have opted in based on that security. So we can't really show the impact because we can't get to what is being exchanged very well. So it's hard for me to show impact in that area. We track advanced care planning. Those are easy documents and they're accessible in the records, and our APRNs have access to those. So that is something that we track very, very closely. And then of course just APRN turnover and the amount of staff turnover. The types of variables that are sort of systems level variables are things that we track and try to impact every day. Hopefully our model, because in nursing homes, at least in the United States, nursing home care has always been viewed as the last resort. Nobody wants to be there. Nobody believes they provide good care. The only way you can get good care in the United States if you're an old person and you're not able to live at home is to be in the hospital. We are trying to change that notion. We want old people that feel like they that cannot live at home, that have to live in these types of settings. We want them to feel like we're providing as good, if not better, care than the hospital. And that's a whole philosophy change. So it's more than just each component. It's really an overall philosophy of understanding how to make this components work together to change that notion. And sustainability. We told CMS, our provider, we said we cannot continue to do this when we're done in 4 years. This was last year before October. When we're done with this, what will happen is that the nursing homes that have implemented all this will not keep it going because it's too financially much stretched. They're stretched to the margins as it is. There needs to be a sustainability model. How can we help them do that? So if we're saving you money, how are you going to sustain this project? And they decided to pay the nursing homes. And that's a very different model. There are no payment systems for nursing homes other than based on acuity. And this is not so much based on acuity, it's based on prevention, which is a very different model in itself. Yeah, it might be. Each of the seven sites that I mentioned that were funded under this, initially under this, were funded to prevent hospitalizations. 2 of the 7 were not refunded. They were not funded the second time. So the 5 sites that are left all have models that were effective in reducing hospitalizations. And they're all very different. Some of them use telemedicine. Some of them are, like ours, uses a different model. Some of them use registered nurses and not APRNs. One of them focused on dental care and providing good dental care to elderly populations. So in reaction to your question, I think that each model was a different approach to the same problem. And so they're trying to determine what would be the best model or combination of models to implement in a national setting. Every other setting outside of these 7 national demonstration projects are providing the same are getting the same types of care that they've always had. So this is not being rolled out anywhere beyond just these 7 sites right now. So. And yes, President Obama's healthcare, initiative, it's and our changing infrastructure and our administration is certainly changing the perspective of healthcare, and changing taxes and how taxes are paid, and changing the funding stream behind those healthcare decisions. And so, we'll see how that goes. Well, I've been in nursing homes, and I've been to probably between 30 and 35 nursing homes between Brisbane and Adelaide. And so I've been to quite a few, and I've interviewed administrators in each of those homes. And one of the things that I find comparable is that the amount of resources that your aged care facilities have in respect to laboratory types of access, radiology types of access, and the infrastructure required to really exchange good data, timely data about residents in these facilities is very low. And I mean very low. And it's the same way in the United States. But I'm just completing a 4-year study. I'm in my last year, where I trended adoption levels in clinical support, which is lab, radiology, and pharmacy, and resident care. And I'm doing that same baseline assessment here in Australia. And what I found in the United States is that there are improvements in technology, and I'm equating that with technology. So in nursing homes that have greater levels of laboratory technology to talk about lab results reporting, oftentimes have, we've done some regression analysis that show that it has improvements in their urinary tract infection rates. And I believe that's because people get information better, they can get antibiotics on board quicker, and the patients get better, and they won't be transferred to the hospital. So there are some links and connections with quality measures and use of information technology that I'm making in the United States that have not been made before. And I came here to do that similar thing. And Cherie has been huge in getting me surveys. Frequently, she's coming to my office giving me surveys. So I've been really, I think I've got not a lot of surveys, but I've gotten 60 or 70 back, I think. And I've got about a month to go in my evaluation. So I'm hoping to have a maybe 15-20% response rate, maybe 100, 150 homes that I can compare how much technology they use in their facilities, and hopefully look at quality measures in relationship to those, is what I'm doing here. It's just very different than this, but you can see the connections, hopefully. I think that's where the innovation comes in. I think creating innovative ways to exchange information about residents and making sure that exchange is meaningful and helpful to decisions about care are really critical. Then there's 2 or 3 parts to that. First of all, providing the tools, innovative tools that nurses and nurses' aides use to communicate about care with physicians who are not typically on site is really critical, because if that message from the nursing home, from the nurses and nurses' aides, is not communicated clearly and succinctly and appropriately to the physician, then the orders are not going to be correct. So there's some innovation there that needs to happen with our communication tools, and those have not been a huge focus in nursing homes. Again, nursing homes are the laggards. They're the people that people don't want to go there. They don't want to work there. They don't want to live there, but they just do not think about it. But we have 16,000 nursing homes in the United States, and you have not that many here, but you have many, many nursing homes here with many people living in them that deserve the same level of care. And then the resources that they have, the infrastructure, and convincing our governments to what it's going to take to help them build their infrastructure to provide an equal level of care is really important. And so that creates innovative models, and that may involve things like telemedicine. So I think telemedicine is something that is a way of the future here and there. How are we going to implement that to get physicians and advanced practice nurses connected to the most people in the best way possible? That's a good research area, I think.
Okay, so on that note, So thank you very much. I'll give you this as a token of
Thank you.
our
You didn't have to
support.
do that.
Now,
Thank you.
Greg's doing a lot of work here as part of his Fulbright's, fellowship. So you're going to be doing some work on an IT roadmap that's going to compare America, Australia, and Britain.
Yeah.
You're doing the survey, so that's going to be very interesting, and probably a few other pieces of work. So we're very much looking forward to the results of your study.
Thank you.
Thanks very much.
Thank you. Thank you. Thank you.